particularly in areas where there can be some long travel times, is an issue that has come up quite regularly in some of the services that we have worked with. And trying to figure out how to allow for that in the stat model, can be a little bit difficult. But there's a couple of things I would say. So one is in working out your demand calculations, you might work out, okay, you need to have 2 home visit initial appointments per week. So you might allow those, 2 mornings a week, when those are put in the, in the clinician's diary. But you might also have some other rules or protocols in place to help to make that process a little bit easier. So one might be that certain days might be allocated to certain regions, for example, or you might have some sort of communication system where, depending on how your appointments work, where let's say this is an OT service, where the OT can put in that appointment slot, a particular region, or going to be near whatever town or something like that, or northwest only, please, or something, to give the person booking into those appointments a little bit of an idea about what's going to fit with where you're traveling. So, if you know that you've got an appointment that's going to be in your north region, then you might book your review appointments that are in that area at the same time. So it doesn't mean that the stat model doesn't mean that the person has to be booked into the absolute next available appointment. You might need a bit more flexibility around that. If you've got 6 appointments in the diary, 6 home visit appointments over the next 2 weeks available, that it might be the third next appointment when the OT is going to be in that right area. So that might be the one that they book into. So you can have some flexibility and communication between the people who are booking the appointments and those who are attending them. I think the thing is to sit down with your service and nut this out, and the people who are making the appointments and the people who are carrying them out, to work out, to try and come up with a system that's going to work. Because you certainly don't want to have a situation where you're being sent, 100 kilometres one way and then 100 kilometres the other in the afternoon. Definitely important to take it into account, but it can be figured out. The way most services that we've worked with have ended up doing this is they work out, okay, if they've got 4 physios on their team, for example, and they work out that each physio needs 3 a week or 5 a week, whatever it is, to keep up with demand, and that's kind of worked out on a pro rata basis for part-time clinicians. It's ideal if you can get a bit of a spread across the week so that there's some choices for patients. There might also be some, if a patient has seen a particular clinician in the past and wants to see the same clinician again, it allows for them to be booked into a clinician appointment with that clinician. So yeah, whoever's then making those appointments, following that initial referral, just book them into kind of whoever's got the next available spot. Or they might also consider other things, like have they seen a particular person before, or is there someone whose skill set's particularly suited to that person? But yeah, they will be booked into a particular clinician's diary. And that can be a little bit tricky, especially if the person who's booking in those appointments is not sort of keeping track of who's been going to which one. Again, I think that's about trying to set up a communication strategy within your team. So maybe it's look, it's hard to say because it depends on the particular service, but let's say, thinking about some of the other services that we've worked with, just having some kind of mechanism where the clinicians can communicate with the intake person or whoever's doing the bookings to say, low intensity clients only, please, this week, or something like that. Something just to let them know that they've actually got like a fairly heavy caseload, at a particular time, and to just to have a little alert that they still keep seeing people, but perhaps anyone who's going to be particularly intensive might be to share around to other people. So that might be one way to do it. Any other suggestions on that, Catherine?
Yeah, I think when you're setting up your initial numbers for the calendars, so if you've got a senior clinician who's more likely to be taking complex cases, you might give them slightly less initial assessments, because they're going to be given, you know, much more complex patients. So, and there might be a more junior clinician who's going to get the straightforward ones, and they might have more of those case appointment spots. But again, it's something that you've just got to monitor and change as you go. And the appointments don't need to be fixed in the diary, so that they can be changed around. And I guess you could potentially give, if I'm really busy next week, I could say, Catherine, have you got time for me to give you one of my new assessments next week? So long as it's the correct number overall, it doesn't really matter how they're arranged.
And this might be a problem more in some services than others, where you have quite, you know, and I imagine some regional services, this might be the case where you've got, you know, quite a mix of clients. Yeah, and there's no reason to why you might not allocate certain types. Some appointments in the schedule might be allocated to particular patient groups, for example. This happens, you know, has come up in some of the community health services we've been working with, who have, you know, some parts of the service that are fee for service or NDIS, and others that are community health. So you might have a certain number of appointments that are attached to each funding stream. Well, there's no reason you couldn't use a similar principle to divide your client load into, you know, kind of high and low intensity, or certain types of, you know, and have clients that sort of roughly fit into the two categories and can be sorted into those two different appointment types, for example. So there's quite a few different ways you could do it. No, that's a good question. I think what I would say about that is, I think the most important aspect of this is to recognise this problem and to be prepared. So it's kind of hard to answer this for any without knowing more about a particular service and the model of care. But what I would say is that this is a really good discussion to have with your team, and to sit down and say, okay, if we have this situation, you know, what could go? So what would be, you know, what would be the first things that we could drop off to try to keep room for our new people coming in? Because what you don't want to do is have this situation, take all your new appointments out of the diary. So say you're supposed to have 15 a week, you've got someone who's gone off, you know, on unexpected leave, and now you've only got, you know, 5 in the diary or 10 in the diary, you know, half as many as what you need for the next however many weeks, and find that you get further and further out of control. So thinking about, is there something else that's less important that could go, so you can still keep that flow through happening at the right rate? That would be something to think about.
I've been working with Catherine on the STAT project for quite some time, and I've just thought of an example at one of the services we've recently worked with came up with for this sort of a problem. So it was a community paediatric service, I think for speech therapy, and they were expecting an influx post-COVID lockdown. And they were concerned about how they were going to integrate, you know, a kind of bolus of new referrals. So they were going to block out in the next school holidays, they were going to block out a week and have sort of an assessment blitz in anticipation of a whole lot of new referrals coming in. And that was something that they came up with, but this model's really a principles-based model, and it's up to organisations, you know, how they manage the flows of referrals that come in.
That's a really good example, but I think what it really highlights is the importance of having those conversations well before anything actually happens, so that you've got a plan in place for when it does. This is something we found really hard to measure directly, mainly because a lot of because our projects have been over multiple different services. It's really hard to kind of have a generic patient outcome that can be collected across all clients that would allow us to measure this. So often, you know, it's quite the sorts of measures services use are very specific to their clients. Having said that, we have measured things like the number of appointments received, and the time from the first to the second appointment, and we've actually found that most of those things, it actually hasn't made much difference. So I think what we're observing is that there are a lot of services where the supply and demand actually is quite well in balance. So people do those demand calculations, and then at the end of it, they say, oh, that's actually about what we're doing anyway. So what they're being asked to see in terms of throughput is not very different to what they were being asked to see before. The real problem is that entrenched backlog. So if you can get rid of the entrenched backlog and then get this in process, so you've got that number of people flowing through regularly, you'll have some busy periods. But it just means that when you hit those busy periods, the result is not a growing wait list again. You can kind of push through those busy periods without developing a wait list. So, you know, when that's the case, what you actually find is that clinicians aren't actually, the service that's provided to patients is actually not much less than what it has been in the past. We did find in the first community rehab trial that we did, one of the differences it did make is that people moved to groups slightly earlier, but, you know, we're talking about people having an average of 12, you know, appointments, and then, you know, 5 in a group versus, you know, 10 or 11 and then 6 or 7 in a group. You know, it wasn't massive, it was just a slight shift. And I'd be very surprised if that was enough to impact on outcomes. But look, you're right, that is something that within each service you'd want to keep an eye on, and is certainly, you know, there's potential for more research in that area. My first response to that would be that the starting point shouldn't be about what's the appropriate clinical workload, it should be about what's the demand. So once you've established what the demand is, you know, how many patients need to be seen each week to keep up with demand, then it's about saying, is that reasonable? And if it's not, having those conversations with your team and saying, okay, our demand figures are telling us we'd all have to see, you know, 3 new patients a day. I think that's too much. What do you think? And if they all agree that's too much, well, then you've got to decide what, you know, what you're going to do next, or how are you going to get the service to all of those people. And that might be saying, okay, well, we'll see this many, you know, through our traditional model, and this many will have an education group or something else, or we'll tighten our referral criteria or whatever. So I think there are no tools as such that I know of. There's certainly for particular client groups, there'll be evidence in the literature, you know, looking at dosage for particular therapies and things like that. So, you know, you might want to be guided by that and say, look, there's no point providing, you know, one therapy for stuttering based on, you know, one appointment every 4 weeks. That's not going to make any difference clinically. So if that's your clientele and the evidence is, you know, that from clinical trials is telling you these children need weekly therapy, well, then you might need to decide, well, which ones are going to get weekly therapy, and where else in the caseload are we going to cut corners because we haven't got enough resources for that.
Can I just chip in there too? I think this is a really interesting question, because for some workplaces, the model means a really huge change from clinicians deciding or having intake meetings where they volunteer to take a new client, and it changes to a decision being made about what is fair and equitable between clinicians in a team, and it being very transparent about who gets new clients. So that can be a shift in how people work, and it can be a bit uncomfortable, but there's often people who really like the fact that it's decided very openly and transparently, and it makes for a more equitable caseload sometimes.
Yeah, well, certainly the evidence that we have from the clinical studies that we've done shows that the STAT model does reduce waiting times. If you wanted some more information on that, it's probably the next place to go would be to have a look at the some of the papers that we've published that are on the website. So that will give you the details of the trials that we've done and the degree of reductions of those wait lists. But mostly in our trials, we've tended to look at this mostly in terms of waiting time, so time from referral to next appointment. But the other thing is that I'll just add also is that there are some other papers in the literature about other models that have share some common elements with STAT, not all of them, but some of them. So one is around, there's one in particular that I've come across recently in a systematic review we've been doing that's been used in mental health the choice and partnership approach, the CAPA model, that's popping up quite a bit. As I said, it's all in mental health services, but it's very similar, and a lot of the research around that has actually looked at numbers of people on wait lists and has found, you know, quite dramatic drops in numbers on wait lists. You know, obviously numbers on wait lists and waiting time for appointments are very closely related, and they're just, you know, different ways of looking at the same problem, really. Look, I think what it really comes down to is supply and demand. It's about making sure that you've got the right number of people going through your service overall relative to the number of referrals coming in. So, you know, if you've got 10 referrals coming in a week, you've got to find a way to see, you know, to at least offer that initial assessment to 10 new patients, and then work out what you're going to do with each of them. So some of them might, you know, it might be discharged after that first assessment. Others might require, you know, more treatment. But it doesn't really matter which days you see them on, or, you know, how you actually organise the clinic. I think it's about trying to find a way to try to look at what's going to be the most efficient for the use of your resources. But it's really about the most important thing is starting with that demand calculation.
So I was just going to share a screen quickly. This is our website. Yep.
Thanks, Annie.
So just talking about publications and does it work and all the rest. So we've got a lot of publications at this point, which you're very welcome to have a look at. We've also got a handbook that you can download. So we do have hard copies of it if you'd like us to send a couple, but you can download this handbook, and it explains it in very plain English, what the model's about, and should be fairly easy to follow. And there's various other things here that you might want to look at, including upcoming workshops that we run, which are a half day, and as Katherine mentioned, they're a lot more interactive. So this one next week is booked out, but we've got one on in June that you can register for. Thank you.
It's hard to answer that for every service, but I think that's a very common thing that happens, is that once you're in the door, you kind of have you have the right to the next appointment, you know, that you need for a review before somebody else off the list. And quite often, you know, somebody's 5th or 6th or 8th appointment may not actually be needed as much as somebody who's, you know, waiting at home after being discharged from hospital with their hip fracture and has been sitting at home for 4 weeks not having anything. Quite, you know, there would often be scenarios where that person's first appointment, the need for that really does outweigh the need for a, you know, a 3rd or 4th or 5th appointment for somebody else who's kind of, but those two things are never compared to each other. So this model really helps to overcome that problem.